The Whipple Procedure Explained, a comprehensive guide. Introduction. Welcome to today's episode, where we'll be discussing one of the most complex and fascinating surgeries in modern medicine, the Whipple procedure, or Pancreaticoduodenectomy. Whether you're a medical student, a health enthusiast, or someone seeking insight into pancreatic surgery, this episode will break down its indications, surgical steps, potential complications, and outcomes. What is the Whipple procedure? Let's start with the basics. The Whipple procedure, medically termed pancreaticoduodenectomy, is a major surgical operation mainly performed to treat tumors located in the pancreatic head, periampullary area, distal bile duct, or duodenum. The operation involves removing several interconnected structures and then reconstructing the gastrointestinal tract so it functions properly after surgery. Indications for the Whipple procedure. So, when is a Whipple procedure necessary? Here are the primary indications. Pancreatic head adenocarcinoma. This is the most common reason for the surgery. Ampullary carcinoma. Tumors at the ampulla of Fada. Distal cholangiocarcinoma, or cancer of the bile duct's lower end. Duodenal tumors, including adenocarcinoma, cysts, and neuroendocrine tumors. Chronic pancreatitis, but only in select cases where pain or complications are intractable. Benign cystic neoplasms, such as mucinous cystic tumors or IPMNs with high-risk features, and, though rare, severe injuries from trauma may also prompt this surgery. Surgical steps. How is the Whipple performed? The Whipple can be performed using open, laparoscopic, or robotic-assisted techniques. For clarity, we'll focus on the classic open approach. Here's a step-by-step overview. 1. Patient positioning and incision. The patient is placed supine, usually with a midline or subcostal incision to access the abdomen. 2. Exploration and assessment. The surgeon examines the abdominal cavity to check for metastases and assess tumor involvement with major vessels. The Kocher maneuver is key here, mobilizing the duodenum and pancreatic head for better visualization. 3. Resection phase. This stage involves removing the gallbladder, dividing the common bile duct, and choosing between a distal gastrectomy or preserving the pylorus. The jejunum is divided about 10-15 centimeters beyond the ligament of Treitz, and the pancreatic neck is carefully transected. Lymph nodes are also cleared, and the specimen, comprising the pancreatic head, duodenum, distal stomach, gallbladder, distal bile duct, and proximal jejunum, is removed in one piece. 4. Reconstruction phase. Anastomosis. The gastrointestinal tract is now reconstructed. The surgeon connects the pancreatic remnant to the jejunum. Pancreaticoduodenestomy. The bile duct to the jejunum. Hepaticoduodenestomy, and either the stomach or duodenum to the jejunum, depending on the technique used. A jejunostomy is also performed to ensure bowel continuity. 5. Drain placement and closure. Closed suction drains are positioned near the surgical joints, and the incision is closed in layers. Potential complications. No major surgery is without risks, and the Whipple procedure is no exception. Let's break it down. Early complications. Pancreatic fistula, occurring in about 5 to 20% of cases, resulting from leakage at the pancreaticoduodenestomy. Delayed gastric emptying, in 20 to 30% of patients, especially with pylorus. Preserving techniques. Bile leak, affecting 3 to 8% of cases. Postoperative hemorrhage, about 5%, typically from vessel erosion or anastomotic bleeding. Intra-abdominal abscesses, seen in 5 to 10% of patients, often secondary to leaks. Wound infection, another 5 to 10% risk. Late complications. Diabetes mellitus, due to loss of pancreatic endocrine function. Exocrine insufficiency, leading to malabsorption and steatorrhea, often requiring pancreatic enzyme supplements. Strictures, developing in the biliary or pancreatic anastomosis. Recurrent disease, if the original indication was malignancy. Prognosis. Outcomes vary depending on the underlying cause. For benign disease, long-term survival rates are excellent. In pancreatic cancer, if caught early and completely resected, 5-year survival rates are around 20 to 30%. For ampullary or duodenal cancers, 5-year survival improves to approximately 40 to 60%. Conclusion. To sum up, the Whipple procedure is among the most demanding surgeries in abdominal medicine. It requires a highly skilled hepatopancreatic biliary surgeon to minimize complications and maximize outcomes. Recent advances in minimally invasive approaches, including laparoscopic and robotic techniques, have further improved recovery for many patients. Thank you for joining us today. If you found this episode helpful, be sure to like, subscribe, and stay tuned for more in-depth medical explorations. Catch you on the next episode of the Everything Surgery podcast. Dissect the Extraordinary.